Welcome to our presentation on improving multidisciplinary team attendance between hospital and community teams. This project will explore the challenges faced by community-based staff attending hospital ward rounds and how that can affect collaboration and patient care. Presenting this case study will be Group A, Table 5, and this is who is part of our group.
In this presentation, we focus on Case Study 1. This case study highlights challenges faced by community teams where inconsistent attendance of community-based staff at hospital MDT ward rounds has negatively impacted patient care and service efficiency. The main issue identified is poor engagement and communication between hospital and community teams, which has resulted in delays with decision-making and risks to patients with complex needs. Our proposal will focus on improving attendance and engagement at MDT meetings by implementing a structured virtual attendance system supported by clear leadership and communication processes. To analyze this problem, we have used the 5 whys techniques in this presentation, also a PEST framework, a change model, the PDSA cycle, Gantt chart, and a SWOT analysis. A contingency plan has also been developed to ensure the change is structured and sustainable.
The overarching aims of our change is to improve MDT attendance and engagement, enhance collaboration between hospital and community teams, and ultimately ensure measurable improvements in patient-centered outcomes. By achieving these aims, we address the root cause identified in our 5 whys analysis.
Whilst a wide range of key problems can contribute to the lack of communication between hospital teams and community teams, using 5 whys analysis will demonstrate that the core problem is the lack of structured leadership with hybrid attendance in the MDT meetings.
Risk management is an important factor in care and is essential in delivering good and high quality of care to patients. Risk management includes key components to ensure risks are prevented in care. The components consist of risk identification, assessing risks, and risk reduction, which reduces the chance or likelihood of risks happening in care. In this case, it is evident that poor quality of service and care was delivered to patients due to poor ineffective communication between the hospital and community services MDT teams, lack of attendance from staff, which is a risk. Poor MDT meetings can lead to inaccurate or false data about patients, cause confusion in treatment plans, medical errors, and overall appalling decision-making for patients, which puts a patient's health and safety at risk. According to Health and Care Professionals Council, it is important for professionals to take the necessary actions to lessen the risk of harm to patients, families, carers, and healthcare professionals. It is also a priority for healthcare professionals to ensure that they should not do anything or enable another individual to do something which could put a patient's health and safety at risk. Errors in medical and treatment plans due to poor MDT meetings can put a patient's health and safety at risk. Working safely and securely is crucial for MDTs. Working safely includes effective risk management, following the health and safety legislation. A significant part of practice is ensuring the environment is appropriate and safe to use and safely manages risks. Colleagues from the community team joining MDT meetings online whilst working from home can experience issues with securing, storing, or sharing personal information about patients. The Data Protection Act 2018 controls how healthcare professionals gather and share personal information about patients. It protects patients' medical records. Some of the risks regarding community staff working from home during MDT meetings and sharing patients' personal information and medical records include issues and errors with Wi-Fi systems, unsecured systems, viruses, and technological issues.
Analyse inconsistent attendance at MDT ward rounds. The 5 whys technique was used to identify the root cause. Community staff frequently missing ward rounds, largely due to increased remote working post-pandemic, which makes engagement more challenging. There is currently no structured virtual attendance system, leading to unclear expectations and limited accessibility. In addition, MDT meetings are often organised around hospital priorities, meaning community staff are unintentionally overlooked. Ultimately, the root cause is not individual behaviour but more systemic issue relating to lack of shared leadership, structure and effective communication. This highlights the need for structured and collaboration approach to improve MDT meetings and engagement. To understand the wider context affecting MDT meeting attendance, we conducted a PEST analysis to explore any external factors that influence poor attendance. So when looking at the PEST analysis, it's political, economic, social and technological. So the political factors is national and local NHS policies emphasise integrated care, highlighting the importance of effective communication between hospital staff and community staff. Economic factors, poor communication can lead to inefficiencies, duplication of work and increased service costs, which then puts pressure on of limited resources. Social, patients with complex needs rely on coordinated care, so inconsistent MDT attendance can directly impact patient outcomes. Technological, whilst digital communication tools exist, they are not being fully utilised to support virtual attendance or collaboration, which is limiting staff engagement. This analysis demonstrates that the problem of poor MDT meeting attendance is not isolated. It is influenced by broader systemic factors, and any change innovation must consider these external factors to be successful.
The proposed change is the introduction of a hybrid MDT communication system, allowing both hospital and community staff to attend meetings either in person or virtually using secure platforms such as Microsoft Teams. This addresses key barriers identified in the scenario, including remote working and a lack of structured MDT communication. A standard operating procedure and clear communication pathways will be introduced to improve consistency and accountability. This approach aligns with NHS priorities for integrated care and flexible working, whilst also supporting professional standards for collaborative practice. Overall, this change aims to improve communication, enhance coordination between teams, and support safer, more patient-centred care, whilst also supporting current policy on remote working within the NHS.
We have used Lewin's change management model to structure the change as it provides a clear and structured framework for improving MDT communication. It is widely used in healthcare to support organisational change due to its simplicity and practical application. In the unfreeze stage, the need for change is identified through poor MDT attendance, communication failures, and reduced collaboration between hospital and community teams. These challenges can negatively impact patient safety and continuity of care. This is particularly relevant as integrated care systems aim to improve coordination between hospital and community services, highlighting the importance of adequate MDT communication. Identifying the root cause and highlighting that it is a systemic issue helps to create urgency and prepare the staff for change. Within the change stage, we implement a hybrid MDT communication system, including ward round access, clear communication pathways, and defined attendance expectations. Leadership is essential here to support staff and encourage collaboration across teams. In the freeze stage, the aim is to embed the changes into routine practice by standardising MDT processes and monitoring attendance. Ongoing evaluation using the PDSA cycle supports sustainability and continuous improvement. This approach also aligns with the NHS change model, which emphasises leadership, engagement and embedding change into practice to achieve sustainable improvements across healthcare systems. Similar to Lewin's model, it focuses on preparing individuals for change, implementing improvements collaboratively, and embedding these into organisational culture, reinforcing the need for a structured and leadership-driven approach for improving MDT communication.
Personal leadership is particularly relevant in this scenario, as it supports operational change by creating a shared vision for improving MDT communication between hospital and community teams. This is essential when introducing new systems such as hybrid MDT meetings, which require both engagement and cultural change. Democratic leadership also plays a key role, as effective multidisciplinary working relies on collaboration and shared decision-making. This approach can help reduce the us versus them dynamic identified in the scenario and improve team cohesion. Additionally, situational leadership allows leaders to adapt their approach depending on teams' needs, recognizing that staff may have different levels of experience, confidence, and engagement. Using a combination of leadership approaches ensures that the change is responsive, sustainable, and focused on improving patient-centered care in accordance with HCPC and ORCOT values. The implementation of this change will follow a structured and phased approach to ensure it is both feasible and sustainable. The process begins with stakeholder engagement to identify key barriers to communication and ensure that both hospital and community perspectives are considered. This promotes ownership of the change and reduces resistance. The design phase introduces the hybrid MDT communication system, including structured meeting agendas and clear communication pathways. A pilot phase is then used to test the system in practice and gather feedback. Staff training ensures that all team members are confident in using digital tools and following consistent communication process. Finally, the system is implemented across services with ongoing monitoring. The Gantt chart provides a clear timeline for each stage, supporting evidence, effective leadership, organisation, and coordination of care, ultimately improving patient outcomes. Without affecting leadership structures, implementation, communication issues are likely to persist, continuing to impact the patient outcomes.
EDSA cycle is a recognised quality improvement method used to support structured and effective change within healthcare. In this case study, it provides a framework to test and refine our proposed change innovation. In the planning stage, inconsistent MDT meeting attendance was identified as the key issue, and structured virtual attendance system was developed. This will be trialled on one ward over 2 to 4 week period, where data and staff feedback will be collected. The study phase will involve analysing whether attendance and engagement have improved, while identifying any emerging barriers such as technological challenges. In the final stage, the intervention will either be implemented more widely or adapted based on findings. This approach ensures that the change is evidence-based, sustainable, and supports MDT communication, ultimately enhancing patient-centred outcomes. This reflects occupational therapy's role in delivering person-centred, outcome-focused care through continuous evaluation and adaptation of interventions.
A contingency plan is essential to ensure that our proposed change remains effective and sustainable in practice. In complex healthcare environments, when working across hospital and community settings, there are multiple potential risks that can impact the success of implemented change. For this change we want to implement, these could include ongoing reduced MDT attendance, resistance from team members, technical challenges with computer systems, and limited engagement from community teams. To address this, we have developed a structured contingency plan that identifies potential risks, their impact, and appropriate mitigation strategies. For example, reinforcing attendance expectations through leadership, providing staff training, and guaranteeing access to IT support can help to reduce barriers to implementation. If these strategies are not effective, actions can be implemented such as escalating concerns to senior leadership, adapting the MDT format, or using alternative communication methods like telephone or secure messages can be implemented. This approach aligns with the World Health Organization, which emphasizes the importance of proactive risk management, strong communication, and system reliance to ensure safe and effective patient care. Overall, the contingency plan supports the sustainability of the change by preparing for any challenges that may be anticipated and managing them effectively, helping to maintain consistent MDT communication and improve patient outcomes.
The SWOT analysis identifies strengths such as existing MDT structures and digital tools, whilst weaknesses include poor communication and inconsistent attendance. Opportunities focus on improving collaboration through hybrid working, whereas threats include resistance to change and technical issues. Overall, it highlights the need for a structured communication system to improve MDT effectiveness and patient care.
In conclusion, ineffective MDT communication can compromise patient safety and disrupt continuity of care. The proposed hybrid MDT communication system is designed to strengthen collaboration between hospital and community teams, ensuring information is shared efficiently. Employing appropriate leadership styles facilitates the successful implementation of this change, while a structured implementation plan ensures feasibility and sustainability. Overall, this approach advances patient-centred care, improves coordination and supports safer, more efficient service delivery.